bad news, the pressure to live a perfect Instagram life, it is all taking a toll on our minds. Staggering new figures show 15.5 million Americans have been taking antidepressants for at least 5 years. The rate has tripled in the last 18 years, and there are similar statistics in the UK, and women are twice as likely to take these antidepressants. So what is going on? Dr. Alan Francis helped write one of the go-to manuals for diagnosing mental illness, and now he's ringing the alarm bell, warning us that these pills are not only hard to quit, but they're destroying our own faith in our own human resilience. His book, Saving Normal, explains how we fix this broken system. He joined me earlier this week from San Diego. Dr. Francis, welcome to the program.
Thank you very much.
So, I just wanted to start by saying, who knew that antidepressants were addictive? It's not what you associate with things like antidepressants. You think of painkillers and obviously drugs and alcohol and cigarettes.
Well, they're not really addictive in the sense that benzodiazepines are addictive, or cocaine or alcohol. They don't cause the same degree of functional impairment when you're taking them, but they definitely do have a withdrawal syndrome, and that withdrawal syndrome traps people. It's so easy to start an antidepressant and sometimes so very difficult to stop it.
And how did you find that out? I mean, how much science is there on the difficulties, and how do people know when they've been on it too long? Or it seems such a fluid area of medication and prescription.
Well, it's a deeply held secret. There's been almost no research on the withdrawal syndrome. There's absolutely no interest on the part of the pharmaceutical companies in advertising the fact that getting on an antidepressant may trap you for years and maybe for life. So they've discouraged research. They don't report adverse findings. The pharmaceutical industry is only marginally less ruthless than the drug cartels, and it's not in their interest to advertise this. So there's been very, very little research. And we really don't know how the long-term use of these medications may affect the brain. We're doing a kind of public health experiment on hundreds of millions of people around the world without really understanding the long-term effects.
New figures from the New York Times show that 15.5 million Americans have been taking antidepressants for at least 5 years, and that rate is almost double since 2010 and more than triple since 2000. How easy is it to actually get the prescription in the first place?
There's nothing easier in the world than starting an antidepressant. Primary care doctors are given far too little time with their patients. And the only way they can get a patient out of the office satisfied after a 7-minute visit is to write a prescription. 80% of the antidepressants are prescribed by primary care doctors, usually after 7 minutes, under heavy pressure from both the patient and from the drug company to prescribe the medication. On the other hand, stopping the medicine can take years. That it requires, for some people, a very, very slow taper. And without that, they'll have symptoms of return of anxiety, of depression, flu-like physical symptoms, and often they will misattribute these return of symptoms to thinking that they're getting depressed again, when in fact it's just the result of a withdrawal side effect.
And the actual symptoms while one is on these antidepressants can vary as well. There's potentially a lack of sex drive and other such side effects. What are some of the side effects? Weight gain?
The antidepressants cause almost ubiquitous changes in sexual interest and performance, and this can result in serious relationship problems. They frequently cause weight gain, and sometimes very dramatic weight gain. The antidepressants can cause apathy, less motivation. And in a deeper sense, they reduce the person's pride in their own resiliency.
I'm fascinated. You talked about some of the demographics. So from some of the studies in the New York Times research and articles, it seems that some of the majority of these antidepressant pill poppers are women over the age of 40 or 45 or so. Is that correct?
It's become absolutely ridiculous. 1 in every 4 women in America after the age of 40 is taking an antidepressant on a regular basis. Um, the use now is ubiquitous, so that amongst younger women, it's something like 1 in 8. And even amongst teenagers, where the antidepressants have no proven value, except for very classic severe depression in a teenager. They shouldn't be used in teenagers. No proven value, and there's a risk of increased agitation, increased suicidal ideation. Even in teenagers, the rate is 4%. So the drug companies have made antidepressant use a ubiquitous part of our society. And that's very good for their profits, very good for the executives, for the shareholders. It's not good for most of the people involved.
Well, in fact, there is one woman who is one of the people who you focus on in your book, and it's Sarah. And just to remind again that 80% of antidepressants, you say, are prescribed loosely by GPs after an interview that usually lasts less than about 10 minutes. So this Sarah says she was misdiagnosed as being a depressive when she was really just very sad and grief-stricken about the suicide of her son. And she told you, quote, "The doctor was clinical, brushing aside my fears and my loss. I needed someone who would understand and share the pain that I was going through, not put a cold medical label on it." How much of that kind of situation and diagnosis did you see as you were doing your book?
Well, I think that she's a particularly poignant, heartbreaking case because her son had actually himself been mistreated, overprescribed medication. It caused side effects. He actually killed himself with the medication he was prescribed. She's feeling grief, and after a few minutes, a doctor overprescribes medication for her. This is a very common story. I think people have to become educated for themselves, their family members, and particularly their children, not to accept a quick diagnosis of depression, not to accept a pill. The diagnosis of depression should take not just one session, but normally weeks and sometimes even months. Most people come to a doctor on the worst day of their life. If nothing is done except watchful waiting, support, advice, most of those people will get better in the short run. What's happening now is they get a very quick prescription of a pill, and then there may not be an endpoint because stopping the pill will be so difficult, and the person will assume that the pill is keeping them well.
Well, let's play a little bit of devil advocate, because you make a bit of a distinction between situational grief and feeling really low and then proper depression. I mean, there is some benefit, isn't there, to be treated potentially with medication, even for a situational amount of feeling low. Is there or not? I mean, can one sort of micro-target like that?
Well, let's be very clear. There's a cruel paradox that we're over-treating the worried well, and we're terribly neglecting the really ill. And that the medications are absolutely essential for people with severe depression. There's no one-size-fits-all. It's not that medicines are good or bad. Medicines that are very effective for the few become harmful only when they're misused with the many. But I think in terms of situational depressions, short-term reactions to job loss, divorce, financial troubles, it's always better to watchfully wait, and psychotherapy is by far the preferable first-line treatment instead of medication.
So
it's also cheaper.
Is it cheaper, really?
It's a lot cheaper if insurance companies would let primary care doctors have time to talk to their patients. Because most of those patients will not need medication on a second or after a third visit. Instead, they're rushed. The easiest thing they can do is prescribe a pill, and a lifetime of medication is far more expensive than short-term psychotherapy or watchful waiting.
Wow.
The insurance companies are making a terrible financial decision. It's not just a bad clinical decision, it's a terrible financial decision.
So what is your solution then to this overdiagnosis crisis? I don't just mean from the doctors to have more time, but people. How should individuals be sensitized and made aware of this problem?
Well, I think you're doing that, and I'm trying to do that with this program. I think that there are several things that need to be done. The first and most obvious is that we need to tighten the diagnostic criteria for how physicians and people regard clinical depression. We need to tame the pharmaceutical industry. They should not be advertising directly to consumers. That happens only in the U.S. and New Zealand, and both countries have remarkably high rates of antidepressant use. We need to convince the insurance companies to allow primary care doctors to get to know their patients so that their only recourse is not writing a prescription. And most of all, we need to inform the public to be more afraid of medication and less afraid of their emotions and of illnesses. I think that the overwhelming clinical experience and research finding is that most people with transient, mild depressions will do very well on their own. And people should trust to their own resources, get support from their family, get psychotherapy way before they consider medication. The medication should be the last resort for people who have severe chronic depression. It shouldn't be a means of treating the aches and pains of everyday life.
Really fascinating. Dr. Alan Francis, thank you so much indeed.